All of you know that the Red History is one of the treasures of the EBMT. We are not only collecting stem cell transplants, but we are also patients being treated with CAR T cells. We have reached this kind of magic number of 30,000 patients being treated with CAR T. And I know that the collaboration from service centers have been increasing over time, so I really have to thank you very much, all of you, for all the efforts to make the EBMT registry as global and as complete as possible. But let's go back to these highlights in EBMT and elasticity. I think that we have been able to put together really a very nice program with different speakers that will be tackling and touching on the most important or most relevant aspects in the field of stem cell transplantation and CAR T. I really hope that you will enjoy the meeting, that it's profitable for all of you. I want to thank once again Professor Alaskar Nurkaya, that is capital person in the organizing of the meeting, all the speakers that have dedicated time and efforts to prepare the presentation, all the chairs, and of course all the local speakers that during this meeting will complement specifically the information coming from EBMT and of course from elasticity. So I wish all of you a wonderful meeting. Again, a pity that I cannot be here face to face with all of you, and I will see you in the next few hours with my presentation that it's also going to be with. Thank you very much for the invitation and congratulations for the review.
Thank you, Anna, and thank you for your support. And looking forward to again signing and renewing our collaboration very soon, and to enhance this collaboration further. And looking forward to your talk in this program later.
Thank you.
Thank you.
Very much.
All right, moving on with our program, I would like to invite Dr. Ayman Hijazi. Dr. Ayman, consultant and previous head of adult hematology at King Abdulaziz Medical City, Riyadh, National Guard. Please, Dr. Ayman, to present.
Thank you. Assalamu alaikum. Good morning, everybody. Everybody is awake, widely awake. All right. It's my pleasure to present on behalf of the Saudi Society of Blood and Marrow Transplant the Ssbmt Hematology Career Achievement Award 2024. The Ssbmt recognizes outstanding individuals who have made significant contributions and clear impact in the field of hematology at the local and international level. This could be in the form of research, teaching, developments, and advancement in the field, etc. The objectives of the Career Achievement Award is to emphasize the Ssbmt commitment to enhance hematology career in Kingdom of Saudi Arabia, to recognize highly performing achievers in the field of hematology, and to establish an incentivizing culture in the hematology community in the Kingdom of Saudi Arabia. The winner of this year of the Career Achievement Award is a Mecca boy, where he was born. After graduation from medical school in Cairo, Faculty of Medicine at Azhar University, he was awarded a Masters in Clinical Hematology from the Imperial College in London. He was also awarded Fellowship of the Royal College in Hematology, London, FRC Path, Fellowship of the Royal College of Australia in Hematopathology, Sydney, FRCPA, and Fellowship of the Royal Irish College of Physicians, Dublin, FRCPI. He was appointed as a faculty member at King Abdulaziz University, Faculty of Medicine, in 1992. where he held several positions, including he was the head of the Department of Hematology for 3 periods. Of the achievements he accomplished in this position, he started the British Hematology Fellowship Program in the department, and it was the first university hospital blood bank in the kingdom. He was also an assistant dean of the Faculty of Medicine and Medical Sciences. He was the founding dean of the College of Applied Medical Sciences for 4 periods, Director General of King Fahd Medical Research Center from 2010 to 2016, the Regional Advisory by the Royal College of Pathologists. He was a member of the Supreme Committee of the Saudi Commission for Health Specialties, and he's a founding member of the Trustees Committee of the Faculty of Medicine and Medical Sciences at Al-Batarji College in Jeddah for 4 periods. He's the founder and former president of the Saudi Association of Friends of Sickle Cell Anemia and Thalassemia, and the founder and former president of the Saudi Society of Blood Transfusion Medicine. He was a founding member of the Saudi Society of Hematology. Of the awards he gained the Research Excellence Award from King Abdulaziz University in 2014, Achievements Award honored by the Saudi Society of Hematology and Saudi Society of Blood Transfusion Medicine in 2019. He has more than 130 individual and joint scientific papers published in internationally accredited scientific journals. The winner for Ssbmt Hematology Career Achievement Award in 2024 is Professor Ghazi Abdullah Damanhouri. I would like to invite Dr. Asker and Dr. Mohammed Shahrani, the president and the vice president of the Saudi Society of Blood and Marrow Transplant, to hand over the award. Professor Ghazi, come to the stage, please. Alf Mabruk. Well, in the schedule, it seems that we're having yes, a word from Professor Damanhouri.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين محمد صلى الله عليه وسلم. Ladies and gentlemen, my colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, of course, I would like to extend my thanks to and gratitude for this generous invitation by the President, Professor Ahmed Al-Askar, and the esteemed members of the Saudi Society of Blood and Marrow Transplantation. It is indeed a great honor to have this prestigious achievement award, and I'm deeply appreciative of this opportunity. I was asked actually to deliver a short, brief address, not to be more than 5 minutes, and actually I was wondering what I can say in these few minutes. Anyhow, As I look back on my career, I'm filled really with gratitude for the opportunities I've had to contribute to the field of hematology, whether it was through our work on postgraduate education or the development of the premarital screening programs for sickle cell anemia and thalassemia, or for the development of research at King Fahd Medical Research Center at King Abdulaziz University. All these achievements were made possible by the collaborators of the dedicated faculty of members, my colleagues, researchers, and students. Their dedication and support made this journey incredibly rewarding. I have short message actually I'd like maybe to deliver to my really young fellows and the young generation. My advice to them really, I'd like them to participate as much as they can in research groups and also clinical trials, okay? Because really, I hope that our young generation should look at scientific research as not as important or essential, but it is as a vital in their careers. And in my opinion, research is essential for them to be also distinguished doctors, physicians, and good contributors to their society. It should be really forefront of their interest. Now, in order to do so, they must be armed with sufficient knowledge of maybe, in my opinion, three things. Critical thinking also. They should have also really knowledge about strategic planning, and also they should have a control of their time. That will make really their vision and message and reaching to their goals is much better than our generations or the previous generations. We have to remember that life is shorter than we expect, and time is more precious than we think. Therefore, must we don't waste it. Ladies and gentlemen, I would like to end the talk with a word of wisdom للإمام الشافعي رحمة الله عليه. And I think really, I like this really, this word of wisdom, because and you can really use it in your field, in the place you are working in your institute. What he said? He said, victory in all differences is a losing battle. And we do forget that winning hearts is better than winning positions. الانتصار في كل الاختلافات معركة خاسرة، وننسى أن كسب القلوب أولى من كسب المواقف. اللهم اجعلنا من المتحابين فيك، والسلام عليكم ورحمة الله وبركاته.
We haven't started our scientific program, but it seems that in the schedule we have a short break for coffee. So we'll grab some coffee for 10 minutes and then we'll be back to start our scientific program. Thank you.
fellowship training was in Paris. So he focused on the targeted therapy of hematology and pregnancy. He is a co-author for more than 400 articles and in leading scientific journals like New England Journal of Medicine. He is the chairman of BMT, Leukemia Working Party, chairman of NCCN Lymphoma Group in the Middle East. He garnered multiple awards in 2008. So he was getting in 2022 King Hussein Lifetime Achieve Award. So without any further delay, Dr. Ali, the mic for you.
Thank you very much for the kind introduction. Assalamu alaikum, sabah al khair. I would like first to thank the organizers of the Saudi Society for Blood and Marrow Transplantation, particularly Dr. Ahmed Al-Askar, for the kind invitation. I'm delighted to be here with you. شرف كبير لإلي إني أكون معكم اليوم. So today I will be talking about preventing post-transplant relapse in acute myeloid leukemia. So as you know, relapse of AML is the first cause of a transplant failure and the first cause of mortality after allogeneic transplant, whether in the setting of sibling transplant and even in unrelated donor transplant. It is far above the other transplant complications or transplant-related mortality. And actually, despite significant improvement in recent years for young patients, the prognosis of AML in relapse after transplant remains dismal. So this is a large study that we performed on behalf of the Ssbmt Acute Leukemia Working Party, and you can see the overall survival after relapse, after transplant. So you can see that, well, we improved somehow from 16% to 26% for patients younger than 50, no improvement for patients older than 50, but still 3/4 of young patients and 80% of older patients are dying when they relapse after transplant. So with all of this background, why to prevent relapse after transplant? Well, we have seen that it is the first cause of transplant failure for obvious reasons. No patients and no doctors would like to see relapse of AML. Treatment of relapse post-transplant is suboptimal for most diseases, and treatment of relapse post-transplant is likely more expensive than prevention for most diseases. So the initial attempt was, this idea is not new. It was quite old. Even 3 decades ago, we had this publication about donor lymphocyte infusion, trying to foster adoptive immunotherapy and graft versus leukemia effect. And you can see that it worked very well for chronic myeloid leukemia at that time in 1995, although today we are almost not transplanting CML patients anymore. But for AML, the effect of DLI alone was quite modest. So people moved to maintenance therapy with post-transplant pharmacological interventions, and you have multiple candidate agents. I would say the 2 most developed are hypomethylating agents and FLT3 inhibitors, and we have a lot of ongoing studies with venetoclax and IDH1 or IDH2 inhibitors. So we have learned some lessons even outside the transplant setting. So the idea of maintenance therapy in AML is not new. And we have this HOVON study published in 2019, showing that azacitidine maintenance after intensive chemotherapy prolongs disease-free survival and overall survival, even though the p-value was not significant for OS, but significant for DFS. And we have the famous Quasar AML-001 trial using oral azacitidine maintenance post-intensive chemotherapy. And in this randomized double-blind placebo-controlled phase 3 trial, you can see that we have almost 10 months improvement in median overall survival when using oral AZA versus placebo. So that was after intensive chemotherapy. What about using hypomethylating agent maintenance after transplant? Well, we have some good background and rationale. Not only hypomethylating agents would act on the leukemic clone. I think that the most of the effect that we will see later is acting on the adoptive immunotherapy, because hypomethylating agents will increase the expression of tumor-associated antigens, will increase the expression of KIR ligands on hematopoietic cells, recovery of reduced expression of HLA class 1, class 2 on tumor cells, which is a way tumor cells escape a graft versus leukemia effect, increased expression of non-minor antigens, and increased expression of FOXP3 and Treg, so here acting on the donor cells. All of these effects would foster graft versus leukemia effect. And you can see here some examples from these two blood publications showing azacitidine upregulating the expression of epigenetically silenced putative GVL target. So the first study reporting results of azacitidine as maintenance post-allo was published by Marcos de Lima in Cancer in 2010 about maintenance therapy with low-dose AZA. And this was a phase 1 dose-finding study, and importantly, the recommended dose is much lower than the standard dose of AZA. It is 32 milligram per meter square daily for 5 days. And then we have Charlie Craddock publishing the UK phase 1-2 RICAZA trial of adjunctive AZA after RIC-Allo in AML MDS with DLI if relapse or mixed chimerism. And in this study, one important finding, again, stressing on the importance of graft versus leukemia effect, is that survival was much better for patients who had CD8 positive T cell response to tumor antigens compared to those who did not have. So it is mostly a graft versus leukemia effect. So at AUB with Jean Sheikh in 2017, we reported this study on 18 high-risk patients, 13 AML and 5 MDS. 28% of patients had residual disease, active disease, and additional 2 had refractory leukemia. Half of the patients had either high or very high disease risk index. So they received prophylactic Vidaza, and at the 1-year DFS and overall survival were 63 and 70%, which is quite encouraging in this high risk setting. And then the French reported in 2019 combining azacitidine and donor lymphocyte infusion, and again you can see survival at 3 years of 66% with a very nice plateau, 11 AML and 9 MDS. Then came the randomized trials. Basically, there are 2 of them. The first was done by Betul Oran from MD Anderson, a phase 3 randomized study of 5-azacitidine maintenance versus observation. So this was a relatively small randomized study. 87 patients, AML, MDS, or CMML, they received only 4 cycles of azacitidine. This is the shortest maintenance ever. I mean, most recommendations are for 2 years, 3 years. The minimum is 1 year, but 4 cycles. And the study was negative with 4 cycles, as you can see here. However, in the same study, in the subgroup analysis for patients who received 9 or more cycles of azacitidine or of placebo, those who received AZA had improvement in relapse-free survival. So the limitations are short duration of treatment and inclusion of FLT3 ITD, which require, we will see that later, another type of maintenance. Then we have this bigger randomized trial by Chinese groups published in JCO in 2020, combining decitabine with GCSF versus placebo. So this study included 204 patients with high-risk AML and CR who were MRD negative after allo, and patients were randomized to receive GCSF, decitabine, or no intervention. And you can see a major improvement in leukemia-free survival and overall survival. And again, immune cell subtype monitoring revealed a significant increase in CD8 and regulatory T cells and NK cells by the second or third cycle in the decitabine GCSF group. And finally, we have this meta-analysis of maintenance post-allo showing that hypomethylating agents improve disease-free survival, relapse-free survival, and overall survival. So now moving to the most established maintenance therapy in AML post-allo transplant, which are FLT3 inhibitors. So you know that FLT3 mutations are the most frequent mutation in acute myeloid leukemia. Basically, we have 2 types of mutation. The internal tandem duplication, 25 to 30% of patients, and the point mutation in the activation loop, around 7%. So the FLT3 ITD increases the risk of relapse, decreases survival, and the impact of finding these mutations on therapy is important, because, both for indication for allotransplant and for incorporating FLT3 inhibitors in different settings. But even after allotransplant, the prognosis of patients with FLT3 ITD was significantly lower than those with wild-type FLT3, particularly when FLT3 ITD was not combined with nucleophosmin-1 mutation. So this was a large study from the Ssbmt Acute Leukemia Working Party. And then at AUB, we published this first pilot study in 2015, almost 1 decade ago, on 6 patients receiving sorafenib maintenance post-allotransplant and to prevent relapse. And you can see after a significantly long follow-up for some patients, none of the patients had relapse. And this was reported in clinical lymphoma, myeloma, and leukemia. Then we moved on to perform a multi-institution study between AUB Saint Antoine and King Faisal in Riyadh. And in this publication that included 27 patients receiving sorafenib maintenance, 2-year leukemia-free survival 75%, 2-year overall survival 83%. So these are quite outstanding results for a high-risk disease like AML with FLT3 ITD. Then we did an analysis within the Ssbmt registry comparing patients who received sorafenib maintenance to those who did not receive sorafenib maintenance. And in the pair match analysis, you can see that we have significant improvement in leukemia-free survival from 53.8% with placebo to 79.1%. And please remember these numbers. I will come to that later. And this was associated also with significant improvement in overall survival. Then we had in 2020 the publication by the German group of the randomized trial, the Ssbmt trial, testing sorafenib against maintenance. And people always criticize registry studies, saying that these are retrospective, but indeed they are the reality. And here you can see that the results of the German randomized trial were identical, the 53-point-something% for, I mean, these were exactly the same number that we had in the Ssbmt registry study. So showing that sorafenib improves outcome, overall survival, and relapse-free survival. Then we had the Chinese randomized trial published in the Lancet Oncology in 2023. And after a 5-year follow-up, we have significant improvement in overall survival and leukemia-free survival due to decreased risk of relapse post-allo. And importantly, in this trial, that sorafenib benefit was observed in all subgroups, regardless of whether patient received pre-transplant sorafenib or not, and regardless of whether they were MRD positive or negative after transplant. And this is very important when we will compare with other drugs. And actually, we had a very elegant study published by the German group in Nature Medicine in 2018, showing that indeed sorafenib promotes graft versus leukemia activity in mice and humans through IL-15 production in FLT3-ITD mutant leukemic cells. So again, when post-transplant maintenance works, it works mostly through inducing a graft versus leukemia effect. So what about other FLT3 inhibitors? We have midostaurin, which is standard in first line combined with chemo, but after transplant, the difference between midostaurin and placebo was not impressive. We have the Quantum First with quizartinib, and you can see overall survival in patients who received allotransplant in CR1. There was no difference for MRD negative patients, significant improvement in MRD positive patients. And finally, the famous Morpho trial, gilteritinib versus placebo as post-transplant maintenance in AML. So overall, this trial failed its primary endpoint. There was no difference in relapse-free survival or overall survival between gilteritinib and placebo, and that was because gilteritinib induced a decrease in the risk of relapse, but increase in non-relapse mortality. But then the authors performed a subgroup analysis by MRD status, and actually patients who were MRD negative did better than MRD positive. This is expected. But those who were MRD positive had improvement when they received gilteritinib in relapse-free survival, no difference in overall survival, and those who were MRD negative, no change. But the problem is that this relapse-free survival benefit was only observed in North America, where the control group had poor outcome. And you can see, for example, on your right-hand side, the upper panel in Europe, the outcome for placebo patients was better than for those who received gilteritinib. So FLT3 inhibitors are not equal, are not similar. They are not FLT3 inhibitors. They target FLT3 for sure, but many other kinases are targeted. And the broader kinase inhibitory activity of sorafenib makes it effective on inducing graft versus leukemia effect and makes it effective in improving outcome in MRD positive and MRD negative patient with improvement in overall survival. And based on that, we had published in 2020 the clinical practice recommendation on allotransplant for AML patient with FLT3 ITD. This is a position statement on behalf of the Acute Leukemia Working Party of the Ssbmt, and you can see that post-transplant maintenance therapy with a FLT3 inhibitor for patients who underwent allotransplant is recommended, except if active GVHD, and in the absence of an appropriate clinical trial, sorafenib could be considered as the preferred option. And actually, the NCCN guideline followed us with this recommendation. In 2023, you can see that we have recommendation for FLT3 inhibitor maintenance. Sorafenib is listed as first option. The other options with a star category 2B, sorafenib is category 1 based on 2 randomized trials. And this is my final slide. This is Ssbmt survey on practice pattern of transplant centers regarding maintenance treatment post-allo. So this was presented by Dr. Iman Abu Dalle from AUB, sorry, at the Ssbmt meeting. 115 centers, 89% implement maintenance strategy, 64% of centers use hypomethylating agent, mostly azacitidine, 83% use FLT3 inhibitors, predominantly sorafenib. Thank you for your attention.
So, thank you so much, Dr. Ali, for this fascinating talk, comprehensive and elegantly you give our overview about post-transplant stem cell treatment, maintenance. So now, thank you, Dr. Ali.
So please have a seat, Dr. Bodabashi. We will have the question session at the end. So now I have the pleasure to introduce our second speaker today, Dr. Lama. She is a consultant adult hematology at King Abdulaziz Medical City, Riyadh. She is also assistant professor in Sohail Abdulaziz University for Health Sciences, and she has special interest in acute lymphoblastic leukemia and histiocytic diseases with many related publications. So she's going to talk about chemo-free therapy in Ph-positive acute lymphoblastic leukemia. Dr. Hind.
Okay. Thank you for the nice introduction, and thank you for giving me this opportunity. Today I will talk about chemo-free approach in Philadelphia positive acute lymphoblastic leukemia. We know that Philadelphia positive acute lymphoblastic leukemia is common in older patients, and this makes the treatment challenging because usually elderly patients do not tolerate chemotherapy well as younger patients. It consists of 20 to 30% of patients with acute lymphoblastic leukemia. Before the TKI era, it was a dismal prognosis with 12% only overall survival. However, after TKI and chemotherapy and transplant, it reached to the best 50% survival rate. And I will show you through this presentation that this is even better with the chemo-free approach. I will start with a question to the audience. So how many of you would transplant in first CR a young patient with Philadelphia positive ALL who had a donor and achieved complete molecular remission? How many of you would transplant them in first CR? Afi? None? 1, 2? طيب. So maybe there is no point of this talk, but we'll go ahead and see. Okay. So I will start first with the first trial from the German group, the Ssbmt group. Usually the German group, they pioneered the chemo-free approach back in 2005, I think, when they look at tyrosine kinase inhibitor dasatinib plus steroid only in Philadelphia positive ALL, and they were surprised by the complete hematological remission of 97%. However, the complete molecular remission was only 18%, and definitely 50% of the patient relapsed later. So then they designed the D-ALBA trial, where they look at addition of blinatumomab to the dasatinib and steroid. And this is the design of the D-ALBA trial, where they started with steroid pre-phase, and then they gave dasatinib and steroid for 85 days as induction. And then whatever the response, they move and they give them blinatumomab 2 cycles and with dasatinib. And they look at the primary endpoint was the molecular response after 2 cycles of complete molecular response after 2 cycles of blina. Those who achieved complete molecular response, they went and they give them 3 more cycles. And of course, they give CNS prophylaxis in form of intrathecal chemotherapy, 12 cycles. They included in this phase 2 trial 63 patients, all of them newly diagnosed Philadelphia positive ALL. There was no age limit. They included up to 89 years old patients. And as I said, the primary endpoint was sustained molecular response. They observed at the previous study 98% complete response or complete hematological response. At day 85, which is end of induction, 30% of the patient had a molecular response, complete molecular response. And this increased after 2 cycles of blinatumomab to reach 60% complete molecular response. Recently, they published their long-term follow-up at 53 months. They found that the disease-free survival was 75%, overall survival was 80%, and event-free survival was 74.6%. 93% of those who achieved complete molecular remission did not require allo stem cell transplant. And to mention here, they left the decision of allo stem cell transplant to the investigator. 24% had allo stem cell transplant in first CR. The transplant-related mortality was 12.5%. Patients with MRD negative who did not have transplant as per investigator choice and who were in CMR, they did not require transplant. They remain in CMR without transplant. This made you question whether those 24 patients really needed transplant or no. 9 patients relapsed in this study, and they look at the relapsed patients, and they found that 4 of them had I-cross zinc finger plus mutation, and those patients later acquired the T315I mutation. And we know that I-cross zinc finger plus is a lead to genomic instability and acquirement of many mutations. Also, this made you question whether if they use ponatinib or something to target T315I, maybe we could have avoided the four relapse here. Also, there was no difference between the P210 relapse and the P190 relapse. However, the duration from the time of relapse from the complete hematological remission was more in the P210. There was 4 CNS relapse, isolated CNS relapse. So they concluded that chemo-free induction and consolidation with the dasatinib and blina associated with high incidence of molecular response and survival and few toxic effect, and it was tolerable by older patients also. Then a group from Memorial Sloan Kettering Cancer Center looked at the same study, but I just want to mention in the previous study, those who relapse are those who, none of those who achieved early complete molecular remission after induction relapse. Those who relapse are those who achieved complete molecular response later on. So that's why this blissful study looked at introduction of blinatumomab early. Like instead of waiting till day 85, they give the blinatumomab at 6 weeks. So it's the same concept. They included patients 18 years or more, no upper limit of age. They included only 17 patients with follow-up of 11.7 months. They gave them the same steroid and dasatinib, but up to 6 weeks. And then at 6 weeks, those who are in morphological remission, they gave them blina 3 cycles. And if they went into complete molecular remission, they give 4 more cycles of blina. And the maintenance is dasatinib. The duration is left for the investigator. Also, they noticed 100% complete remission rate. 10 patients out of 17 achieved complete molecular response. 2 patients relapsed after achieving complete molecular response, 1 refused consolidation, and 1 had extramedullary relapse with again T315I mutation. And again, why they did not use ponatinib to avoid this relapse. 4 patients underwent allo stem cell transplant in first CR. One had, I think, less than molecular response, and the other one and 2 patients had Icora zinc finger plus mutation. So they concluded again that addition of dasatinib early might prevent relapse and induce early molecular response. And here they came to a conclusion that using ponatinib instead of dasatinib might suppress the resistant clone. We come to the T315I mutation. The French group, the EWAL group, they studied abbreviated chemotherapy and dasatinib and steroid plus abbreviated chemotherapy in older patients with Philadelphia positive ALL. And the number of patients was big, 71 patients. 96 of them achieved complete remission. 36 patients relapsed. More than 75% of those relapsed patients had T315I mutation. So T315I mutation is the commonest mutation that causes relapse in those patients. So based on that, the Falcon trial is a phase 3 randomized trial compared abbreviated chemotherapy with imatinib plus abbreviated chemotherapy and ponatinib in newly diagnosed Philadelphia positive ALL. And the primary endpoint, surprisingly here, was MRD negative after induction, because we know that MRD negative matters after induction, after consolidation, whatever. So ponatinib ponatinib arm reached the primary endpoint. It showed more than twofold rate of MRD negativity at end of induction. Based on this trial, ponatinib and chemo was approved as first line in treatment of Philadelphia positive acute lymphoblastic leukemia. I can say it's the only TKI approved as first line. And interestingly, the safety profile was the same between the two groups. There was no increased vascular abnormalities in patients on ponatinib arm. Now we come to the cream of the talk. This is the MD Anderson ponatinib and blinatumomab for Philadelphia chromosome positive. This is an important study. We know that MD Anderson pioneered the study of hyper-CVAD and ponatinib in patients with Philadelphia positive acute lymphoblastic leukemia. They showed excellent results. However, the older patient did not tolerate the hyper-CVAD, so they designed this study first for patients more than 6 years. And then when they noticed that those patients have early complete molecular remission, they included also younger, all age group, patients from age 18 without upper limit of age, newly diagnosed Philadelphia positive, adequate performance, adequate liver function. They excluded those with uncontrolled cardiovascular risk factors, because of the ponatinib side effects. And they excluded CNS disease, but they included CNS leukemia. So the design of the study, they give ponatinib 30 milligram, lower than the dose that you use in CML 45, and they shift to 15 milligram once complete molecular response achieved. This is to reduce the side effect of ponatinib. Together, they give the blinatumomab to start with on day 1 in order to induce molecular response. The first cycle of blinatumomab 4 weeks and then 2 weeks break, and then they continue with 15 milligram ponatinib plus blinatumomab, total of 5 cycles, and the maintenance was ponatinib 15 milligram, and there was no transplant in CR1 unless the patient had less than complete molecular response, or the patient had Icora zinc finger plus mutation to start with. They did bone marrow after cycle 1 and after cycle 2 and 5 and every 3 to 6 months. The primary endpoint was achievement of complete molecular response at 3 months by PCR, by quantitative PCR. The intrathecal chemotherapy they gave here 15 because they learned from the D-ALBA that there were many CNS relapse, so they gave patients 15 cycles, 3 per each cycle. So as I said, the primary endpoint was complete molecular response rate, and the secondary endpoint was response rate, safety measures, event-free survival, and overall survival. They included 62 patients in this study. 40% were above 60 years. They allowed patients with more than one cardiovascular risk factor, but they excluded those with uncontrolled risk factors like uncontrolled hypertension. The median follow-up was 17 months. 98% achieved complete response, and one patient had early death, and that death was in remission. That patient had a cardiac procedure and died of hypovolemic shock. 67% achieved complete molecular response after one cycle. And interestingly here, they did weekly PCR on peripheral blood, and they noticed that after 2 weeks only, 60% of the patient achieved complete molecular response. So this gave them a chance to even reduce the dose from 30 to 15 even after 2 weeks of induction to avoid the side effects. 84% achieved complete molecular remission at any time, and this is the best result in Philadelphia positive so far. Then they did, for 45 patients, they did NGS as well as the PCR. The primary endpoint was by PCR, but they also did NGS, and they look at the correlation between MRD by NGS and MRD by PCR. And they found that some patients, like 2 patients, had PCR MRD negative, but they were NGS positive. And 5 patients were MRD positive by PCR, but they were NGS negative. So they found that those 5 patients who were NGS positive, they did not relapse, while one of those 2 patients who was NGS positive but PCR negative, he relapsed. So that's why they suggested that we do we rely on the decision of transplant on NGS, not only on PCR. So it's better if you want not to transplant the patient to do NGS as well, and to make sure that the patient is negative by NGS as well. And this is estimated 2 years overall survival. This is really fantastic. So event-free survival rate was 89%, and the overall survival was 89%, almost 90%, and the event-free survival was 77%. 10% relapse, 7 patients actually, after a median of 21 months. 2 relapse in the bone marrow, 1 acquired E225V mutation, none acquired, of course, T315I mutation, 1 had extramedullary relapse, and 3 had CNS only relapse, and in the D-ALBA 4 had CNS relapse. So still we have a problem of CNS relapse on those patients. And TKI did not penetrate the CSF. So they noticed that the relapse here, the CNS relapse, was mainly on patients who had white count more than 75. So they suggested also that those patients with high white count, it's not enough to give only blina and ponatinib. Maybe you need to give like high-dose methotrexate, 1 or 2 cycles, more chemotherapy for this subset of patients to avoid the CNS relapse. 1 leukemia-related death occurred in the study, and only 1 patient underwent transplant in first CR. And that patient underwent the transplant because he had persistently low level of PCR positivity. Most adverse events were grade 1 and 2, consistent with the non-toxicity profile of the 2 agents, and ponatinib was discontinued only in 2 patients because of the possible vascular side effects. So they concluded that chemo-free combination of blina and ponatinib is safe and effective in induction in newly diagnosed Philadelphia positive with high rate of MRD negativity, and maybe there is no need for transplant in those who achieve CMR. Again, the German group, they went back and they tried the same approach of blinatumomab and ponatinib, and they compared it retrospectively with the D-ALBA trial of dasatinib and blinatumomab. Here, for the ponatinib group, they included 88. Remember, in the D-ALBA, they were 60 patients. They induced them, again, they give the blinatumomab late, not early, same like the D-ALBA design, but they reduced the induction period to 70 days. And they give the ponatinib 45 to 30, and they reduce it to 15 once remission achieved. Instead of 12 IT, they gave here 15 triple IT to avoid the CNS relapse. And transplant in CR1 was not left for the investigator as before. It was only for MRD positive or Icora zinc finger plus mutation. And at a median follow-up of 4 months, which is short duration, they found that 95% achieved complete remission in both arms, the dasatinib and ponatinib. 1 patient relapsed in this period from the ponatinib arm, while 3 patients relapsed on the same period in the ALBA protocol. 5 patients went to transplant here, 24 here. The complete molecular response after induction was higher in the ponatinib arm, 27% versus 10% in the dasatinib arm. However, the overall molecular response did not differ between the two groups. But remember, those who achieved early molecular response did not relapse, but those who achieve late relapse, so maybe this will prevent relapse. So this is what they postulate, possibly early MR and less risk of relapse than dasatinib blinatumomab. Can we go without blinatumomab, chemo-free without blinatumomab? Our colleague in China, they published this poster in last ASH, olverembatinib combined with venetoclax and reduced intensity chemotherapy. Olverembatinib, if I pronounce it right, is a new TKI, tyrosine kinase, that is potent against the T315I. It's FDA approved in China. I'm not sure about other areas. So they combine it with venetoclax and vincristine steroid. So it's a single phase 2 arm. They included 31 patients, age more than 14, echo adequate. Median follow-up was 5.8 months, short duration. The primary endpoint was complete molecular remission at 3 months, and it was defined as undetectable BCR-able transcript by using RT-PCR method at sensitivity of 0.001. And the major molecular response was defined as more than 3 log reduction of PCR-able. So this is the design of their chemo. They gave venetoclax 100 milligram. They ramped it up to 400 milligram for 28 days. And they gave olverembatinib 40 milligram daily for 1 month. This is in cycle 1. And steroid was given for the whole month and tapered after on day 15 down. And in the cycle 2 and 3, they gave venetoclax and steroid for 1 week only. And they continue all through with the olverembatinib. And then this is the initial result. They noticed that at the end of cycle 1, this is the end of cycle 1, the complete molecular response was 54.8%, major molecular response 25.8%, and at 3 months of therapy, complete molecular response was 61%, and major molecular response was 32%. All patients achieved complete response at end of cycle 1. No treatment-related deaths occurred. No patient developed relapse or death. The two regimens were well tolerated. Most side effects, the two drugs I mean, most side effects were grade 1 and 2. No patient discontinued any of the medication because of side effects. So this combination is chemo-free and immunotherapy-free, can be offered. It's safe and effective. However, it's, the ponatinib and blina is better, but this can be used when you cannot give blina for any reason. This is the last trial that I will show here without blina. There is the dasatinib and sequential CAR-T. Also, our colleague from China, they give short period of chemotherapy, dasatinib, vincristine, prednisolone for 2 weeks only. And then they give the patient CD19 CAR-T followed by CD22 CAR-T and dasatinib maintenance. So 18 patients received CD19 CAR-T after the 2 weeks of vincristine steroid. 14 of them received sequential CD22 CAR-T. After induction, the complete hematological remission was 100%, and the complete molecular remission after CD19 was 72, and then when they gave the CD22 CAR-T, it was 76. So there was no much difference between no addition of the CD22 CAR-T, I think. After a median follow-up of 13.5 months, 16 patients remained in complete hematological response, 14 patients remained in sustained complete molecular response. There was no patient received allo stem cell transplant, no grade 3 CRS or ICANS observed during CAR-T. My own opinion that this study did not add anything more than what we have already. I don't think CAR-T should be used in first line. So to conclude from that trial, they concluded that CAR-T can be used and avoid transplant and so on. We go back to our question. I think you already answered properly. Would you transplant a patient in complete molecular response if you have a donor? No? Everybody know? Right. So messages to take home. What's the best approach? We understand now chemo-free is the best approach regardless of the patient age. What's the best TKI? I think now from the Falcon trial, we know that ponatinib is the best TKI. Do we need to transplant in first CR? Selective patient, I think, those who had less than complete molecular remission, those who had ICROS zinc finger plus mutation. What's the duration of TKI? If you can give it indefinitely, yes, but at least 5 years, provided that you are monitoring the molecular response frequently. CNS relapse is still CNS relapse in all the studies is an issue. I think more ITs, and for those with high white blood count, we can give 1 or 2 cycles of high-dose methotrexate. With that, I conclude. Thank you so much. Hello?
Thank you very much, Dr. Henry. Please have a seat. We will have discussion at the end. So as I understand, we will continue. And next is every satellite symposium. And I have the pleasure to introduce our next speaker, Dr. David Lewis, who is a consultant hematologist at Plymouth University Hospital and United Kingdom. Dr. David Lewis is a consultant hematologist with extensive experience managing lymphoma patients. He is the principal investigator of multiple pivotal trials. He will give talk about the diffuse large B-cell lymphoma, disease state, current unmet needs, and the therapy advancements in addressing these unmet needs. He will also discuss the T-cell engaging therapy in treating the third line or more relapsed refractory DLBCL with practical management and share his hands-on experience in treating these patients. So Dr. David Lewis, please, Mike.
Well, thank you very much for that very generous introduction. Yeah, I'm David Lewis, and I've come from Plymouth in the UK. Just to talk to you about bispecific antibodies largely and where they sit in the current treatment for diffuse large B-cell lymphoma. Really, there's 3 parts to this talk. The first talk is really highlighting the unmet need of where we are with patients with diffuse large B-cell lymphoma, and I'll try not to spend too long on that because I'm sure you've heard that in other sessions. The second part of the talk, I'm really going to talk in detail about the current evidence for the currently available CD3, CD20 bispecific antibodies in diffuse large B-cell lymphoma. And the final part of the talk, I'm just going to take you through some cases of patients that I've treated in Plymouth. And hopefully we'll have some time for discussion at the end. Here's some disclaimers, and here are my disclosures. So, as I'm sure everyone's fully aware, I mean, actually, with diffuse large B-cell lymphoma, for the majority of my career, the novel therapy that was available was rituximab. But really, over the last 5-6 years, we've had a proliferation of novel agents that have become available in immune activating agents such as tafasitamab, CAR T-cell therapy, of course, which has really changed the management, particularly of relapsed refractory diffuse large B-cell lymphoma, and a number of indications for CAR T have appeared on in the last few years. Antibody drug conjugates have obviously become important in the treatment of diffuse large B-cell lymphoma, particularly in polatuzumab and more recently Lonca-T. And then most recently, the license approvals for these agents, bispecific antibodies. Now, I think we're very much at the beginning of the story when it comes to bispecific antibodies, but we've now got 2 licensed and 1 reimbursed, the other one about to be reimbursed, CD3, CD20 antibodies for diffuse large B-cell lymphoma in the 3rd line setting. And this is what happens to patients with diffuse large B-cell lymphoma, and this is really just to highlight the unmet need. So although the vast majority of patients receive first-line treatment, and we do cure the majority of patients who have first-line treatment with R-CHOP type treatment, but of course there are some patients who can't receive R-CHOP for whatever reason. About a third of our patients go on to receive second-line therapy, and the prognosis and outlook for these patients does remain poor, and these patients have, despite the advancements in treatment, remain a challenging group of patients to treat. And in fact, you can see that a large proportion of those go on to receive third-line treatment after second-line treatment. Historically, outcomes in the chemotherapy era have been very poor with patients with second-line treatment. The SCHOLAR database is a database that made up largely of clinical trial data combined with real-world evidence. And you can see that in the real-world setting, the vast majority of patients who have relapsed refractory diffuse large B-cell lymphoma actually do very poorly, with very poor progression-free survival and overall survival, particularly in those patients who progress quickly after their initial treatment, those patients who progress within 12 months of initial treatment. Now, CAR T cells have completely changed the landscape in relapsed refractory diffuse large B-cell lymphoma for a subset of patients, but they remain challenging to deliver. They're associated with significant toxicity, and they don't cure everyone, as we'll go on to see. So very briefly talking about CAR T, there are 3 randomized studies that have reported evidence that they improve outcomes in the second-line setting compared to standard immunochemotherapy and autologous transplant. The TRANSFORM study, using liso-cel in the second line, you can see showing very high overall response and CR rates and an improvement in progression-free survival compared to standard of care. And of course, the ZUMA-7 study looking at second-line axi-cel therapy with a significant improvement in PFS and subsequently a reported overall survival benefit, which was reported more recently. So because of these randomized studies showing a benefit over chemoimmunotherapy, CAR T cells are now a recognized option for second-line treatment of diffuse large B-cell, particularly for those patients who relapse within 12 months of initial treatment, because those are the patients that are going to do particularly badly with standard chemotherapy approaches. However, CAR T-cell is not without its challenges. First of all, I mean, our UK experience is we've got a limited number of treatment centres. The CAR T is not a treatment you can give in every hospital, and the geography and the logistics of CAR T remain a challenge for a lot of patients. Secondly, there's the fact that the actual CAR T-cell product itself takes 3 to 4 weeks to be manufactured, and so during that time the patient may well progress, and certainly in the UK we have a large number of patients who, despite being referred for CAR T-cell therapy, never make it as far as the CAR T-cell infusion because they progress or become too unwell to actually receive the product in the time that it's being made. The second problem with CAR T, of course, is that even if patients get to infusion, there's a significant relapse rate. So despite CAR T-cell therapy curing a significant number of patients that would otherwise not be cured, there are still patients who will relapse following CAR T-cell therapy. And so there's an unmet clinical need for these patients who will go on to need third-line treatment after CAR T-cell. And of course, CAR T-cell treatment is associated with significant toxicity, with very high rates of cytokine release syndrome and ICANS. And I think we'd all be slightly concerned about taking patients with significant comorbidities to CAR T-cell therapy. So we've improved a lot, and we've got new options, but we can still improve, and we've still got treatment. We still need to offer treatments to these patients who relapse after CAR T-cell. So I think into this space is where our bispecific antibodies are going to sit. So currently we've got 2 licensed agents, CD3, CD20 bispecific antibodies, which have recently been licensed for the third-line treatment of diffuse large B-cell lymphoma, i.e. patients who've had 2 prior lines of treatment. And I'm going to spend a little bit longer going through the studies, the pivotal studies that have led to these licenses. First of all, let's talk about the Roche product, glofitamab, and I will talk about this in more detail later on, but you can see that, remember the scholar data I presented to you before, those patients, this is a very, very poor prognosis group of patients. And you can see that these patients who get a complete response to glofitamab have about 2-year progression-free survival of 63%, which compared to historical controls is really quite impressive. And similarly, a very good overall survival considering this is such a highly refractory, poor prognosis group of patients. The overall response rate in the GLOFIT study was about 50% with a CR rate of 40%. Oh, sorry, I thought I was using the mic. Apologies. Can you hear me okay? Yeah. Talking now briefly about the epcoritamab data, you can see similarly patients who get a complete response have a 24-month progression-free survival of 75%, with again a highly impressive overall survival at almost 90% of patients still alive at 2 years of those patients who get a complete response. With, in the epcoritamab study, the primary endpoint was overall response rate, and similarly, about 40% of patients got a complete response in the GENO-1 study, which I'm going to talk about in more detail in a minute. Would you like me to mic up?
Sorry, doctor. Would you mind pressing this one?
No, apologies. Can you not hear me very well?
Yeah, they can. Sorry.
Is that better? I'll just hold it. Can you hear me now okay? No, not at all. It's got worse.
Doesn't get red. Yeah. Sorry.
There we go. That better? It's all right. I'll use this. This will be all right. I'll just try and talk close to the microphone. So again, highly impressive progression-free survival and overall survival, particularly in those patients who got a complete response. So 40% of patients get a complete response, and you can see highly impressive PFS and OS. I'm just going to drill down now into the clinical trial data to talk through that in a bit more detail. So first of all, coming to the epcoritamab clinical data. So epcoritamab is currently the only available subcutaneous CD3, CD20 bispecific antibody. And remember, I mean, I'm sure people in the room are familiar with bispecific antibodies, but a bispecific antibody is an antibody that is capable of engaging two targets at the same time. All of the currently available lymphoma-directed bispecific antibodies engage CD3 on T cells and CD20 on the target lymphoma cells. Interestingly, it binds to a different epitope on CD20 than rituximab does, which does potentially lend itself the option of combination chemotherapy in the future. And it brings the T cells close to the target, and thereby they kill the cancer cell via cell-mediated toxicity. There may also be some direct toxicity from the bispecific antibody itself, but these antibodies do not engage macrophages in the same way that rituximab does. So the vast majority of their activity comes from redirecting T cells, patient's own T cells, against the cancer cells by engaging CD3 and CD20 simultaneously. Epcoritamab has a unique DuoBody technology developed by Genmab, whereby you get a bispecific IgG1 antibody which are very stable in vitro and in vivo and behave very similarly to regular IgG1 antibodies. And this allows, well, one of the reasons it allows subcutaneous dosing is because it's such a stable molecule. Really, I said to you a few minutes ago, and hopefully you could hear me, I think we're at the very beginning, actually, of the development of these agents. What I'm going to talk to you about in the coming slides is the current indication, which is epcoritamab monotherapy for third-line treatment and beyond of diffuse large B-cell lymphoma. But actually, there's a huge number of ongoing clinical trials in different disease areas and looking at combination therapy as well. A large number of these our centre has taken part in, actually. We've actually given about 30 patients epcoritamab across a number of different clinical trials, but you can see that epcoritamab has been investigated in different diseases, including follicular lymphoma, mantle cell lymphoma, and in earlier lines of treatment than third line. So this is for the future. What about where we are now? So we took part in this study in Plymouth. This was the NHL-1 study, the pivotal phase 1, phase 2 study, which established, first of all, the dose for epcoritamab, and secondly, examined its efficacy across a wide number of different lymphoma indications. I'm focusing today on the diffuse large B-cell lymphoma cohort, which is what's led to its license. I've written the key inclusion criteria on the graph there. You can see that this is patients who had relapsed refractory diffuse large B-cell lymphoma. I just want to highlight to you that this study did actually allow patients in who had an ECOG performance status of up to 2, in contrast to a lot of other studies which have a cutoff at 1. Patients needed to have at least 2 prior lines of anti-cancer therapy. Importantly, and I'll come on to it in more detail later on, prior CAR T-cell therapy was allowed in this study. And I've also put the dosing schedule up there for epcoritamab. So epcoritamab is given in 4 weekly cycles. For the first 3 cycles, epcoritamab was given weekly. Subsequently, it is given every 2 weeks up to cycle 10, and then it's given once every 4 weeks. And the trial protocol was to either progression or toxicity. But I would add another reason to stop the epcoritamab there, which is patient choice. And I actually did have a number of patients that did stop epcoritamab because of choice as opposed to any other reason. The first cycle of epcoritamab is given as step-up dosing to mitigate the risk of cytokine release syndrome, with the first full dose being given on cycle 1, day 15. And the full dose is 48 milligrams. The primary endpoint of the epcoritamab study was overall response rate, but we did collect other endpoints such as duration of response, and CR rate, and overall survival. And I'll talk you through that in more detail over the next few slides. Now, this is a really key slide, actually. I mean, I think when you're looking at a paper or data, it's really tempting to skip, isn't it, to the progression-free survival and OS curve. But I would always look closely at the patient characteristics in any study, because it can be quite cynical, I think, sometimes, that often studies have very selected group of patients. That is not the case in this study, and I want to highlight to you a few things. These were a very, very highly pre-treated, difficult group of patients. You can see, first of all, that the number of prior lines of therapy, the median number was actually 3. And bear in mind that most patients who with diffuse large B-cell lymphoma after their first line of treatment are in trouble. Median number of lines was 3, and up to 11 prior lines of therapy. 40% of these patients had had prior CAR T-cell therapy, of which the majority were refractory. And you can see that 75% of these patients were refractory to at least 2 prior lines of therapy. There was also significant numbers of patients who had double hit lymphoma and transformed low-grade lymphoma. And you can see that although there were relatively small numbers of patients with ECOG2, there were some patients with relatively poor performance status in this study. So this was not a select group of patients who were, this isn't a study where they selected off, if you like, good players. This was a genuinely highly refractory, difficult group of patients. And certainly the patients we put into the study were all very challenging patients. And even despite that, despite this very difficult group of patients, overall about 60% of them responded. So electing partial response and CR rate, with a CR rate of almost 40% in this very challenging group of patients. So, and I think, as we'll come on to in the next slides, but the achievement in a CR really is an important endpoint for these patients. The patients who do really well with these drugs are those who get a CR. Here's the waterfall plot just showing you the reduction in size of the target nodes in each patient, showing that the majority of patients, even so, to actually get counted as a response, you needed to get to that line, because that's a 50% reduction, which would get you to the response. But you can see that even the patients who didn't, strictly speaking, get a response, a lot of patients did have some effect of the antibody. And again, response rates across subgroups, again, really important. I think a lot of people are going to be using these antibodies in patients who had prior CAR T-cell. And the epcoritamab study had the largest number of patients with prior CAR T of any of the bispecific studies thus far presented. And you can see that of those patients who had prior CAR T, response rates were comparable to those who hadn't had prior CAR T, with about 30% getting a CR, even having had prior CAR T-cell therapy. So there was no subgroup of patients that performed particularly badly in this study. This is just showing you what happened to these patients over time, and this is really just to emphasize that responses with epcoritamab tend to happen quickly. The majority of patients, so our practice outside of clinical trial is to do a PET scan at about 3 months of treatment, roughly. That's when I tend to look. And actually most patients will have a CR at that point. You see CRs early in these drugs. There are some patients, though, who get a partial response who do subsequently achieve a CR in a later study, and those patients do equally well. So don't panic if your patient, I mean, obviously you want your patients to get a CR on the first scan, but don't panic if they get a good partial response and they still have some activity. They may well convert to a CR on a later scan, and I would continue the drug in those patients. But you can see the median time to response is quick at 1.4 months. Personally, I don't look that early. In clinical practice, I would look at about 3 months. But in most patients, clinically, it's usually quite clear if they're responding because they get better. And again, those patients who do get a response have an impressive duration of response. You can see that the majority of patients, actually, who have a response, this is including partial responders, do remain in remission. But you can see particularly those patients who get a complete response, where the vast majority of those patients who get a CR are remaining in CR. And again, this graph really highlights the importance of achieving a CR. You can see the patients who get a CR, this is overall survival we're looking at now, actually have a fantastic overall survival, with the vast majority of patients remaining alive. And I would say well, in my experience, alive and well on epcoritamab. You can see that patients who get a partial response, unsurprisingly, do better than those patients with progressive disease or stable disease. But the majority of patients whose best response is a partial response will at some point relapse and go on to need further treatment with something different. This is an experimental outcome of the NHL1 study. They collected MRD by cell-free DNA, which is a very interesting technology for the future, showing that actually MRD negativity was highly prognostic of outcome, with those patients who achieved MRD negativity having a clearly much better outcome than those patients who did not achieve MRD negativity. So I think in the future, MRD may be a useful tool to help us do response assessments in these patients, and may either augment or potentially replace things like PET scans in some patients. The extended follow-up data of the epcoritamab study was presented at EHA this year, showing that those patients who do achieve a CR, again, the vast majority of those, even at 2 years, are still in an ongoing complete response. And that's certainly my experience with our clinical patients. Those patients who get a CR do tend to stay well and in a complete remission. In terms of treatment exposure and discontinuations, most patients, this is with a median follow-up of 10 months, you can see that the patients who have discontinued treatment, unsurprisingly, the most common reason for discontinuing treatment is progressive disease. But I just wanted to highlight to you on this slide that, from a reassurance point of view, that actually discontinuing epcoritamab because of adverse events is actually quite rare. I can't think of a patient I've discontinued it with adverse events off the top of my head, but in the study, about 7% of patients were discontinued because of adverse events. But it's a relatively low number of patients when you think about the cohort that we're talking about. This is a heavily pre-treated group of patients who've had a lot of chemotherapy and are unwell. And this is a continuous therapy as well. So usually with continuous therapies, you do get relatively high rates of discontinuation due to adverse events. So 7%, I would say, is a relatively small number. And in terms of adverse events of special interest, I'm sure everyone in this room now is familiar with cytokine release syndrome, largely, I think, because of people's experience with CAR T-cell therapy. And I think, just to put this into context, the centre I work at in Plymouth, whilst we're a big lymphoma centre and a big trial centre, we're actually not a CAR T centre at the moment. So when we started using epcoritamab in trial, we were actually quite nervous about cytokine release syndrome. But it became very quickly apparent that actually it was something that we could handle quite easily in our centre. So for cytokine release syndrome, you do see it in bispecific antibodies. You do see cytokine release syndrome. But the cytokine release syndrome I think we all are worried about is like grade 3 and above cytokine release syndrome, which is where patients are having to go to intensive care for inotropic or respiratory support. With epcoritamab, you can see that whilst about 50% of patients do get a degree of cytokine release syndrome, it's highly predictable in terms of timing, with the vast majority of patients who get cytokine release syndrome getting it on that cycle 1, day 15 first full dose. And the second thing to say about it is, of those patients who do get it, the vast majority have grade 1 or grade 2 CRS. So grade 1 CRS, as I'm sure you've heard in other talks, is really just a fever. These are basically well patients with a fever. Grade 2 CRS is where patients are dropping their blood pressure or needing a little bit of low flow oxygen, but you can look after them very, very easily on either a day case unit or on a ward. Only 2.7% of patients who had epcoritamab had grade 3 CRS, which is basically a short spell on an ITU, usually for a little bit of inotropic support. As I said, I've treated 30 odd patients with epcoritamab across different indications in clinical trials, and I've not sent a patient to ITU yet for either ICANS or CRS. It resolves quickly in the vast majority of patients, and it only led to treatment discontinuation in 1 patient. So CRS is something you need to be aware of, and it's something that you do need to be able to treat with tocilizumab if necessary, but I would say it's something that shouldn't stop you giving it, and I can say with confidence that you can deliver these drugs in a non-CAR T-cell centre, because we have. With the extended follow-up, we We've also looked at some cytokine release syndrome mitigation strategies, including a different dose ramp-up schedule, which reduce the risk of CRS even further. One thing I would say to you is that the use of dexamethasone in the initial prophylaxis as opposed to prednisolone does seem to lead to a lower rate of cytokine release syndrome. So we've routinely, actually, across our entire bispecific program, including epcoritamab, switched to routinely using dexamethasone instead of prednisolone for cytokine release syndrome prophylaxis, and that markedly reduces the CRS rate. So conclusions from the GENO-1 epcoritamab study. This is the first-in-class subcutaneously administered CD3/CD20 T-cell engaging bispecific antibody. It's a really, really difficult patient subset in this study, and despite it being such a challenging group of patients, including 40% with prior CAR-T, we had a CR rate of 40%, and that CR rate is maintained over time. And if patients get a CR, they are likely to remain in a CR for over 2 years. Adverse events, we do see adverse events, including cytokine release syndrome in about 50% of patients, but it's highly predictable in terms of timing, and it is usually easy to deal with in a ward-based setting. And after that first cycle of epcoritamab, you very rarely see cytokine release syndrome. Very few patients in this study actually discontinued epcoritamab because of adverse events. So I'll talk you through the glofitamab data as well now. So this is the other bispecific antibody which is coming through. This is data that was presented by Martin Hutchings last year. Glofitamab is another off-the-shelf intravenous bispecific CD3/CD20 antibody. I think the main differences in terms of administration with epcoritamab are, firstly, glofitamab is given intravenously, and secondly, it has a limited duration of therapy as opposed to ongoing treatment. We've previously seen with the primary endpoint of the Roche glofitamab study was CR rate as opposed to overall response rate, and they had a CR rate of about 40% in their study. This is their dose ramp-up schedule, which I'll just skip over very briefly, but patients get obinutuzumab on cycle 1, day 1, with then a ramp-up of glofitamab over the following 3 weeks. It's given on 3 weekly cycles up to a maximum of 12 cycles. The indication for glofitamab is almost identical to that for epcoritamab, so diffuse large B-cell lymphoma after 2 or more prior lines of therapy. This study only included patients with equal performance status of 0 to 1. They also had some prior CAR T-cell treated patients in their study. About 30% of the patients in the glofitamab study had prior CAR T. And this was data that was presented at ASH and Lugano, showing that, again, if you get a CR rate, those CRs do appear durable in the glofitamab study. This is a landmark analysis. Bear in mind that this is not a comparable PFS curve to the ones we've seen before, because this is what's called a landmark analysis, which means you only include those patients who reached the end of the study. So by definition, in order to get to this point, the patients would have had to survive for 8.3 months. So this is obviously a selected group of patients, but you can see that those patients who do have a CR at that time point actually do maintain it in the majority of cases. And again, with a selected group of patients, impressive overall survival. And again, they see CRS in about 2/3 of patients. Again, mostly grade 1 and 2, but they did see some grade 3 events, but again, relatively rarely. Okay, so I've managed to skip through that fairly quickly. So I've got some time at the end for case presentations, and then we'll hopefully have some time for the discussion at the end.
You have 5 minutes.
I've got 5 minutes. Okay, that's fine. So this is where I work in Derriford in Devon, concrete monolith. We've got a large active clinical trials centre in Derriford, and epcoritamab was actually one of our more successfully recruiting studies. So the first patient I'm going to talk you through is a 75-year-old male with relapsed refractory diffuse large B-cell lymphoma. Initially presented with stage 4 disease and was treated with polar R-CHP ×6. He had a partial response after 2 cycles, but at his end of treatment scan had disease progression. And this is what his disease looked like. Now, he went on to receive second-line GEMOX, He's 75, and in the UK we can only access second-line CAR-T for those patients who are considered eligible for autologous transplant. So this patient wasn't considered eligible for autologous transplant, so he went on to have GemOx. He had a partial response, but then progressive disease again. Now, he's got very extensive disease, this guy. You can see his PET scan shows a very high total tumour metabolic volume, and his LDH is 900. So this guy's got very proliferative, bulky disease. He's also got some comorbidities. He's got psoriatic arthritis, he's got an ejection fraction of 45%, and he's got renal impairment. And his current ECOG is 1 to 2. So I think this is that really challenging group of patients, and I'm sure we all see these. These are the patients who've got very primary refractory disease. So, what are we going to do? Now, CAR T-cell therapy, in theory, this guy's eligible. He's got third-line treatment, he's 75, but he's very borderline. He's got renal impairment, he's got cardiac impairment, and he's already got a performance status of 1 to 2. He's already received polar R-CHOP first line, so we don't really have any good bridging strategies for this guy. So whilst this guy's eligible for CAR-T, my worry would be he's going to progress in that time of manufacture and he's not going to make it to infusion. Bispecific antibodies, I think, are a good option for this guy. It's an off-the-shelf product. You can give it, and we know, we've seen from the data I've just presented, that about 40% of patients will get to a CR at third line, which is what he really needs. Polar I wouldn't use in someone who'd already had prior polar R-CHOP, so I personally wouldn't use 3. Loncastuximab would be an option for him. A clinical trial for loncastuximab had a CR rate of about 20% and excluded patients with significant disease bulk. So we elected for a bispecific antibody in this chap. He went on to receive epcoritamab. So tomorrow I'm going to do a session on managing epcoritamab and CRS in a bit more detail, so I won't talk about the management of CRS today. So this guy, I think, whilst he's eligible for CAR T-cell therapy, this is a sort of patient where I'd be really concerned that he's just not going to get there. And I think for this group of patients, in the third-line setting, bispecific antibodies actually offer a really, really good option. And we chose epcoritamab for this patient largely because of our clinical experience with epcoritamab and because the subcutaneous dosing makes it actually very easy to give. And as I said to you, CAR T-cell has its challenges, including time of manufacture, which would count against this guy. I'll skip through this just to go on to the second case, because I think I'm running very low on time. So this is a patient who's 62, who had stage 3 diffuse large B-cell lymphoma, which was treated initially with R-CHOP, achieved a CMR on the end of treatment scan, but then had a relapse that was confirmed on biopsy of the stomach. She did go on to receive second-line CAR T-cell therapy, which was bridged with polatuzumab BR, because she'd only had R-CHOP first time round. Got progressive disease after bridging therapy, but did go on to receive the CAR T-cell infusion. Had a CMR on a 1-month PET scan, but then had a progressive disease on the 3-month PET scan. So what third-line treatment option would you choose? And again, the patient's already had polatuzumab as part of bridging therapy, and I personally wouldn't choose that. Loncastuximab again would be an option. It's a licensed option for third-line treatment. But again, in the loncastuximab trial, there were actually very few post-CAR T-cell patients. And again, CR rates of only 20%. Salvage chemo plus autologous transplant. I guess in theory you could try that, but I think the evidence basis for doing an autologous transplant in someone who's received CAR T, I think it's going to be very difficult to harvest them, and giving them chemotherapy is likely to lead to significant morbidity. So I think, again, for this patient, I would personally have a bispecific antibody at the top of my list of things to give. And again, we chose to have give this patient epcoritamab on the basis that actually about just over a third of patients in the EPCOR NHL1 study had prior CAR T, and we know that the overall response and CR rate in those patients is similar to the overall population. And this patient did achieve a CMR. And again, just to remind you that in subset analysis, those patients who had prior CAR T-cell treatment had comparable CR rates compared to the general population of about 30%. So this is a good option for patients who've relapsed following prior CAR T-cell. And I just wanted to put this in at the end, really, which is just to remind you that actually, and this is very much mirrors my experience, that these patients actually are well. These are outpatients. They come to outpatient. They have an injection that takes a minute, and then they go home and they're completely well. And this is captured in the study looking at fat limb scores, which is looking at treatment-related and disease-related symptoms. You can see a rapid improvement in symptoms that's improved by cycle 3, day 1, and continues to improve. So, and that's really important, isn't it? Because we don't want to just make our patients get to remission. We want to make our patients get to remission and feel well. And in my experience, our patients who have this as an outpatient and remain on treatment are very, very well indeed. So, we've got time for some questions at the end, I think.
Yeah, so you're done.
Thank you very much.
Thank you very much.
So thank you very much, Dr. David. So now we have the session for discussion. So we will invite Dr. Ali, Dr. Hind, and Dr. David.
So maybe I can start the first question to Dr. Lewis. You know, in the past and still ongoing, we had always this question that how to sequence these new therapies in these PDL-BCL, whether CAR-T first or whether some of the others. Now that we have multiple bispecific antibodies, the next question will be which one to use in which setting. So very briefly, if you can give, I know you have to see patient characters for the therapies patient has received, so you have to see all the profile of the patient. But if you have multiple bispecifics available for a certain patient, which one will you choose?
So which I think that's an excellent question, and it's actually a very difficult one to answer. I mean, I think it's always very difficult to look across trials. And you can look at patient characteristics in the trials, but broadly speaking, both of the currently available bispecific antibodies are currently available in the same indication, which is up to 2 prior lines of treatment for high-grade BNHL. And both of the studies involved heavily pre-treated patients. There are some slight differences in patient characteristics in the trials, which I highlighted in the talk, such as performance status, and perhaps there were slightly more patients who had prior CAR T-cell therapy in the epcoritamab study. But I think headline figures-wise, both of the bispecific antibodies give you very similar rates of CR. And I think CR is a really important endpoint here, because the patients who do well on bispecific antibodies are those patients who achieve a complete response. In terms of choosing between them, honestly, I think it comes down to mode of administration and duration of treatment, which is where they differ. And I would say epcoritamab is a subcutaneous injection which takes a minute to give. It's got a very manageable side effect profile that I can say with confidence is something that's very deliverable in an outpatient setting in a non-CAR T centre, because we've done it. Glofitamab has a similar toxicity profile, but it is an intravenous administration. And I think it all depends on discussion with the patient and on your day unit capacity and what works well for the patient. Some patients might prefer a continuous therapy. Remember that even though the epcoritamab license is to progression or toxicity, actually you can stop it before that. I've had a number of patients who have been in CMR for 18 months or so on the clinical trial who actually elect to come off treatment. And I've got 2 patients actually who remain in the CMR despite having been off therapy for over 2 years. So I think it's one of those discussions between yourselves and the patient.
Okay. So, Dr. Ayman? Yes.
Thank you for the talks, David. Again, just to follow up on what Dr. Amr has just asked. There are many questions in the mind of the physician now who treats diffuse large B-cell lymphoma because of the new strategies that we have now, and the sequencing becomes an issue. Now, I mean, patients on first line usually R-CHOP, put R-CHIP, and then primary refractory, CAR-T, later relapses, stem cell transplant. First question is, would you use bispecific molecules for bridging to CAR-T? That's number 1. Number 2, relapses, would you choose again a bispecific for those who did not, have not been treated with bispecific before CAR-T? And what's the evidence?
Okay, I think the second part of your question is the easier one to answer, which is post-CAR-T relapses. I think bispecific antibodies are the agents that are currently available that have got the best evidence for efficacy following. So I think the choice of a bispecific antibody following CAR-T cell relapse is quite an easy one, and that they would be my personal top choice of a treatment option for someone who's relapsed post-CAR-T, because they're currently the agents available with the most evidence post-CAR-T relapse. The second question, which was about bridging using bispecific antibodies to CAR-T, I have to say I personally wouldn't, because the reason for that, if a patient on a bispecific antibody gets a CMR, we've just seen data showing that actually those CMRs are really quite durable. So I would just continue the bispecific antibody on those patients who get a CMR because they've got a really good outcome already. And if you give them CAR-T cell therapy, there's a high chance you'll just have toxicity, and you've also burnt that as an option. Whereas what I would do is monitor them, and then if they've got a CR, you've still got the CAR-T option in your back pocket at that stage. So if a patient got less than a CMR with a bispecific antibody, then those are the patients that I might think of going in with CAR-T cell treatment. But if the patient got a CR, I would just carry the bispecific one person.
Forget about CAR-T.
Well, they may not need it. They may, they may not need it.
Okay, thank you. So, the middle.
Thank you, Dr. Mazarashi, for the elegant presentation about the risk of relapse post-allogeneic transplant. So my question about the trial that was conducted for Ssbmt, it was like in the era where midostaurin was not approved at that time, in some of them. And we know now that midostaurin is the standard of care. And from the Ratify study, those who went into CR1, to transplant while in CR1, they did actually remarkably well. The fact that even if you look to the gentretinib data for the OBN receptors, those who did not receive the gentretinib did actually remarkably well, and their data are comparable to what's produced by the Ssbmt data. So make you wonder, with the use of a novel FLT3 inhibitor in upfront setting, do we still need the maintenance therapy for those patients, or should we really adopt the MRD-driven decision for this particular aspect? Because those FLT3 inhibitors are not free from toxicity that we see it in the clinical practice. When you start to initiate FLT3 inhibitor, whatever the type of FLT3 inhibitor, you see the problems coming in post-transplant setting, cytopenia, toxicity, including even increased risk of graft-versus-host disease.
Thank you. These are very important questions. Actually, there are three questions here. The first is regarding the Ratify study. It is true that patients who did allotransplant in CR1 after midostaurin were those who benefited most from midostaurin. However, in the Ratify study, post-transplant midostaurin was not allowed. So we cannot make conclusions because it was not allowed by the design of the trial. However, if you take the best arm of the Ratify study with midostaurin and with allotransplant, results are 15% lower than what we have seen with the Ssbmt trial, with the Chinese randomized trial, and with the Ssbmt registry data, and in multiple multi-institution data. So I would say that this trial did not give an answer about maintenance. However, it gave an answer about allotransplant in CR1. The second question is for patients in the Ssbmt main trial. Most of the patients did not receive a FLT3 inhibitor before, but in the randomized Chinese trial, many patients did, and I showed you the forest plot on sorafenib, whether they received pre-transplant FLT3 inhibitor or not. So in both cases, the sorafenib maintenance was effective, and there was a benefit from sorafenib whether patients were MRD negative or positive at transplant. So, and the third question is about the MRD-driven strategy. The MRD-driven strategy is coming from the Morpho trial, which failed its primary endpoint, so there was no improvement in relapse-free survival, and that showed only improvement in relapse-free survival in MRD-positive patient post-transplant, without improvement in overall survival, even in the subgroup with gilteritinib. And to add more, that this benefit was exclusively seen in North America, where the control group had a significantly lower outcome than that in Europe and then current standard in FLT3 ITD-AML. Conversely, for sorafenib, we have 2 randomized trials that showed an improvement in overall survival regardless of MRD and regardless of whether patients received before or not FLT3 inhibitors. So this is why I think that when you look to the NCCN guidelines, not to be biased by personal opinion, the sorafenib option is put as first option, as recommendation, regardless of what patient received before, and base level and recommendation of level 1A based on 2 prospective randomized trials, whereas the other options with midostaurin, quizartinib, and gilteritinib are put as later on with a star level 2B, not even 2A. And finally, regarding toxicity, it is true that you will not be able to deliver full dose sorafenib in most patients. 400 milligram twice daily. This is the design of the Ssbmt trial. This is the design of the Chinese randomized trial. And this is how we started this adventure more than 10 years ago. However, very frequently we have to decrease the dose and it doesn't matter. And actually, when we did the consensus guidelines of the Ssbmt, I mean, you know how consensus is made. You need to go in the middle. And actually, the majority of the opinion, and this is in the official recommendation, as post-transplant maintenance, it is 200 milligram twice daily and not 400 milligram daily. And both randomized trials did not show any increase in non-relapse mortality with sorafenib. If you look to the Chinese trial, if you look to the Ssbmt trial, there was no increase in mortality, in non-relapse mortality. Conversely, in the Morpho trial with this MRD guided strategy, gilteritinib increased non-relapse mortality.
So still the sorafenib is winner among all the others?
Currently in 2024, I think that the standard of care is sorafenib, and this is from both sides of the Atlantic. In the Ssbmt recommendation, it is sorafenib, and in the NCCN guidelines in North America, sorafenib comes first as 1A, the others are 2B.
So, question for Dr. Hind. You asked the question that stem cell transplant still we need it or not. So, with the limitation of some study you mentioned, high leukocyte, CNS disease, and small numbers of India Anderson trial. So, still we need transplant or not?
With the result that patient who achieved complete molecular remission, not only from India Anderson, from the other trials also, I would not go for transplant because transplant is not free from transplant-related mortality. If we we have the facility to observe the molecular response frequently, and we have an NGS on board, patients who had icosine finger mutation should be excluded before transplant because all the trials prove that they have high risk of relapse and gaining additional mutations. Patients with high white count and CNS, this is not necessary. They should not be for transplant, I think. The only thing that you need to optimize the treatment directed to CNS, like give them more RTs and give them 2 or more cycles of chemotherapy, and that's it, and then observe for the complete molecular response. Only those who lost their complete molecular response or those who have baseline icosine finger mutation should be considered for transplant. Also, in the trial from India, I did not mention that because my talk was only on Philadelphia positive ALL. They looked at the subgroup of CML also. They gave them the same CML with plastic face. They noticed that the CML did not, CMS with plastic face did not do well as Philadelphia positive ALL. So those patients, if they have a donor, better to transplant them. You will differentiate by having the breakpoint 210 and the background of CML, and that's it.
For David, the last question. Okay. So, bispecific and relapse refractory research on as you mentioned, CR 40% and 2 years progression-free survival of around 60%. So, any possibility, I know that we need longer follow-up, but any possibility that bispecific can cure relapse refractory large B-cell lymphoma? And the other question, when do you do allogeneic transplant for these patients?
Okay. Possibility of cure? Well, I mean, we see from those graphs that if you look at the rate of relapse, it is decreasing over time. So I'm always very hesitant to use the word cure, and I don't say that to patients when I'm presenting bispecific antibody. That's a very disease control. But actually, I do think we probably have cures for people. I've got 2 patients that I mentioned who both had very refractory lymphoma, one of which was on their 6th line of treatment at the time we were into the study, who maintained a CMR for 2 years and stopped treatment, and they remained in CMR for 18 months, 2 years since then. So, and this is and remember, of course, the diffuse large B-cell lymphoma, the vast majority of relapses, if they do happen, they tend to happen within 6 to 12 months. So, I think there is, I'm hesitant to use the word cure, but I think yes, I think it is certainly possible that we're curing people. Secondly, allogeneic stem cell transplant. I think similar to I wouldn't allo someone who's got a CMR on a bispecific. The reason for that being that we know that, as we just heard a minute ago, allo is associated with significant TRM, 15-20%, maybe slightly higher in these patients because they're so heavily pre-treated. And actually, the evidence for allo in diffuse large B-cell lymphoma is not that great, I would suggest. And so I think there's a distinct possibility of alloing them. All you might be doing is subjecting them to the toxicity of allo without any real clear benefit if they're in the CMR. So I personally wouldn't allo someone who gets a CR or a bispecific. I would just carry on using bispecific.
So I think we have to stop here for the sake of time because Juma prayer will be shortly. So we have a bus waiting outside, so those who want to go for Juma prayer. In the end, I would like to thank all the 3 speakers, Dr. Badalbashi, Dr. Salama, and Dr. Lewis for 3 excellent presentations. We had a very nice session and question and answer. And I would like to thank the audience for being present here in the morning. Thank you very much. We will meet again at 1 p.m. 1 p.m.